So good day to everybody. It's a pleasure to be here in Mumbai. I'm at the World Congress of Cardiac Imaging and Clinical Cardiology, and my name is Richard Underwood. I'm a cardiologist and a cardiac imager working until recently in London at the Royal Brompton and Harefield hospitals, which are dedicated heart and lung hospitals in London. And also at Imperial College on my academic appointment in London. So the topic we've been discussing here in Mumbai has been the role of PET in assessing cardiac inflammation, such as in sarcoidosis and other inflammatory diseases, and also the role of PET in assessing cardiac infection, such as infective endocarditis, and also device infections as well. So this was my main topic. It was a well-attended session. I hope that everybody enjoyed it, and I'm here just to summarize a few of the key points that I wanted to present during the session. So with regard to PET, this is FDG imaging looking at myocardial infarction. Now it's important to understand what FDG PET imaging does. So FDG is a glucose analog which is taken up not only by cardiac myocytes if they are metabolizing glucose, but also by inflammatory cells such as leukocytes. So if the myocardial glucose metabolism is suppressed by, for instance, diet, so that it is then only metabolizing fatty acids, and if you then see any FDG activity within the heart, particularly around the valves, then what you're seeing is inflammation or the inflammatory infiltrate taking up the glucose. And this is a very sensitive signal of active infection. Now with endocarditis, obviously there are issues to do with the diagnosis of endocarditis. There are Duke criteria with major criteria and minor criteria, and definitions that will allow you to decide whether a patient definitely has endocarditis, definitely does not have endocarditis, or maybe somewhere in the middle where they have, where it is undecided. And this is really the role of PET imaging in these undecided patients. It would be worth your looking up in the European Heart Journal recent guidelines published by the European Society of Cardiology with the first author Delgado. Looking at these guidelines, because these are the most recent guidelines for the diagnosis and management of endocarditis. And these guidelines divide infective endocarditis into potentially endocarditis on prosthetic valves and on native valves. And in prosthetic valves, it actually gives a class 1 indication for FDG imaging for the diagnosis of, in uncertain cases, for the diagnosis of endocarditis, which is interesting because there are some issues with FDG imaging in prosthetic valves. Soon after surgery, you can see activity around the valve, the prosthetic valve, just from natural healing, which does not necessarily mean infection. It's really uncertain how long that natural healing signal will last. Some say weeks, officially 3 months, but actually our experience is that it can go on for much longer. And particularly if there are, if there's a Dacron sewing ring, foreign material, or if surgical adhesive is used in any form during surgery, then these can take up FDG for a long time, many years, even forever. And this will reduce the specificity of the FDG signal for the diagnosis of endocarditis. Now, in contrast with native valves, although it has been thought that FDG imaging is less helpful in native valves, I think our experience would be different, and although the guidelines that I mentioned before would give it a class 2B indication, I would actually elevate that at least to class 2A, if not to 1. Because with native valves you don't have a lot of these problems with FDG. There's no sewing rings or surgical adhesives. So when you do see a signal in a native valve that is potentially infected, then I find that that is very specific for endocarditis. So in our experience, FDG imaging does have a big role, particularly in those patients where you may be uncertain from the diagnosis using the due criteria. Now, that's valves. There's another indication for FDG imaging in potential infection, and that is infected devices. So these would be pacemakers, the generator in a let's say a pectoral pocket. If you're uncertain whether that is infected, then FDG imaging can be very sensitive and specific for infection there. If the question is on the leads in the heart, then that can be slightly more difficult. Very often echocardiography will show small fibrin deposits on the leads, and it's not quite clear whether those are normal fibrin deposits or whether they may be infected. So FDG imaging can have a role there. I would say, though, that again it may be rather insensitive for small, rapidly moving structures such as a metallic lead in the heart. But nonetheless, it is something that's worth doing, particularly maybe for the intravascular leads behind the sternum, maybe in the subclavian vein, where it's difficult to see those by other techniques such as echocardiography. So that would be pacemakers, and FDG in the guidelines does have a definite indication for the diagnosis of infection in pacemaker and leads. There are, of course, other devices. There would be left ventricular assist devices, particularly for driveline infection. And we've seen FDG activity in other areas such as implanted TAVIs in the aortic valve, and also ASD closure devices and things like that. So in summary, I think nuclear imaging techniques in cardiology are alive and kicking. These are some indications which are unique to the nuclear technique. And I think nowadays it is very difficult to practice an all singing, all dancing cardiology practice without access to these imaging techniques. So it's been a pleasure to be here in Mumbai. Thank you very much for listening. The meeting will finish very soon, and there'll be important summaries for you elsewhere to look at live. Very shortly I'm going to go and enjoy the sights of Mumbai before I get back to my own hometown of London. Nice to be with you. Thank you.